We in the United States should be testing about 6 million people a day. We struggle to test 800,000. So you can see why it's difficult for us to stay ahead of the virus or even keep up with it at this point. In terms of percent positivity, that is should be understandable in terms of it's the percent positive in a population. You want that number to be low. It only works if you have robust testing. It only works if I can test everybody in this room. If I only test 5 of you and my percent positivity is low, it doesn't tell me about the other percent of you that are positive and I just never tested. Does that make sense? So that's kind of the issue there, which is why when we have a testing issue, what you look at is hospitalization rate. Hospitalization rate tells you the true burden of disease on your community. If your hospitals start overflowing with COVID patients or COVID-like patients, then you know you've got more circulating disease in your community that's making an impact. So that would be important for you to follow when testing is not great. How do we fight it? Well, in terms of medications, there's about 300 or more now different trials going on. And largely we're looking in the medicine cabinet of what we've had previously to see what works. So we're trying different things to see if there's a possibility that something that's already on the market, some antiviral, some medication that we use for rheumatic arthritis or rheumatoid arthritis, any of these immune modulating medications, we're trying a lot of those to see if they'll make any difference at all. No such luck, though. I went ahead and listed some of the top drugs that you may have heard about in the news or may have read about on Facebook. We'll go ahead and start with the obvious, which is hydroxychloroquine, plus or minus azithromycin, which is called Zithromax. The evidence just isn't there. The good evidence isn't there. When I say good evidence, I'm talking about randomized controlled trials or even randomized trials. A randomized trial means that you just take everybody and you randomize them up. And you remove bias by doing that. Some of the studies that are out there are, a good number of them are observation trials, which you can weight it one way or the other. You can kind of bias an observational study. There's still a lot of studies going on. The most recent study from the New England Journal of Medicine came out July 23rd that said that there was really no difference in terms of those treated with it, plus or minus the Zithromax on mild to moderate cases of COVID-19. So the evidence is just not good. The initial study that came out was actually pretty bad, and that's in the bottom right-hand corner on the VA patients, actually showed a higher mortality rate. So unfortunately, people that had gotten hydroxychloroquine, more of them died than did not. And that's never good. Under remdesivir, that's an IV medication we use in the intensive care unit or use in the hospital. It's a nucleoside analog, which means that that's a class of medications, means it inserts itself into the genetic code and keeps the virus from reproducing. So it basically stops its reproductive cycle. The studies on it show that it reduces hospital time. So if the individual is supposed to be in the hospital, let's say normally it'd be a 14-day stay, it got cut to 7 days. So that's good. Obviously, less time in the hospital is good. We're waiting for the mortality data to come out on it. I think it will come. Right now, the mortality data is not great. And what I mean by that is it's not overwhelmingly positive. It's not like, hey, yay, less people died with this medication as opposed to not getting it. It's there, it's just not statistically significant yet. And when we talk about statistical significance, does that make sense to you? Do you know what a p-value is? P-value of less than 0.05? That's important. And so it's not statistically significant, though we expect the information to come hopefully sooner than later. Convalescent plasma, always a good choice. We use that in Ebola. That's where we find people that have gotten infected by the virus and that survived it, and we pull their antibodies out and we give it to somebody else. So it sounds archaic, but it actually works really well. Dexamethasone is a steroid. There's been good data on lower. It's a cheap steroid, generic. It's lowered mortality in hospital patients. We think that's a class effect. Class effect meaning we think it's all steroids. We don't think it's just dexamethasone or Decadron. We think it's actually a class effect. Heparin's the newest thing that we're seeing that's showing promise. The interesting thing about that, do you remember I showed you the slide earlier that showed the different cells that COVID-19 binds to and how it gets into and all the different body areas? One of the things, too, that I failed to mention, I'll talk about it now, COVID-19 is prothrombotic. Prothrombotic means that it creates blood clots. Unfortunately, it creates blood clots in the venous system and it also creates blood clots in the arterial system. I'm pointing down here because a deep vein thrombosis is typically what you would see. That deep vein thrombosis will cut loose and move into the lungs or into the heart and interfere with oxygenation and can kill the person, if not severely compromise them. Arterial clots, as you might imagine, just thinking about how the arterial system works, they move downstream and basically clot off the blood flow to the organ. Largely, the problem is strokes. So they actually create large strokes to the human brain. It can also cause kidney infarcts as well. But heparin, which is a blood thinner, they were using it for that. It's showing promise, but we were surprised to find out it acts almost like a dummy drug or a dummy molecule. And what I mean by that is COVID-19 seems to want to bind to the heparin. That's pretty cool. I'd rather have COVID-19 bind to the heparin than bind to my cells. And so the idea is that we could use heparin as a template to basically create another drug that you ingest, and now all of a sudden COVID-19 binds to that drug and doesn't bind to your human cells. So that's kind of where the research is going on that side.